Okay, hopefully this will be another short video. This is going to be putting really chapters 2 and 34 together for you from your Hinkle book this week. And I think I just went to, I was like on a different slide. It's Med-Surg nursing, but it's going to be chapter 2 Med-Surg. It's a review of different links that can help you out looking at different nursing for Med-Surg. I think you can pull up the links yourself. We've talked a lot about nursing and AdPi and all the different things that we do as nurses, but it's a good review of some different sites for you. We do help coordinate care when we're transitioning patients from one area to another. Those are the different roles of the nurse as they transition their patients throughout the continuum of care. So just go here to rehab goals because that is the focus of this particular chapter. Know that when you're working with your patients in your long-term care and your acute care rehab settings for this clinical rotation, that you're going to be working closely, doing interprofessional collaboration with physical therapy and occupational therapy. You want to know that your patients have had joint replacements, they've had strokes, they have complex wound care. We are trying to determine when they're in that acute rehab setting for a couple of weeks, getting that therapy, are they safe to go home? Do they need to stay, or, do they need to move over to long-term care, or do they need another solution, like move in with family, something to that effect? We want to promote patients to do for themselves as much as they can. So if your patient has had a stroke, or they have rheumatoid arthritis, whatever it is, maximize their independence. We do not want to do everything for them. I know we walk in and we think, oh, I'm going to totally help them. You can help them, but let them do as much as they can for themselves because we want to promote their independence. Make sure you're doing your functional, your CAT index assessment. You're going to be looking at how well can they do their independent daily living activities. What's their functional assessment? Are they able to brush their teeth, take a shower, go to the store, prepare meals? How are they going to be safe to do those things? The goals for your patient is going to depend on what's going on with your patient. I can say again, don't use risk for falls, use impaired physical mobility. You can also look at, let me think about that, self-care deficits. There's a whole bunch of different activities that you can individualize to your patient under the self-care deficits. So look at those things and try to make them as independent as possible. That is always our ultimate goal. There we go. Same thing. Make sure you're assessing their mental status too, because of course they are going through a change and they're losing some of their independence. Their baseline might change a bit, but help them accept their limitations, talk with them, listen to them, help them use their assistive devices or their adaptive devices. Get occupational therapy and get engaged, especially if they have hand deformities. There's so many things that they can give them to help them perform their own activities of daily living, but with just some modifications. So here's what we want to see as our outcomes. Notice that the word independent is in every single one of those. So we want to foster independence. More stuff for that. You can read that yourself. You need to know how to position your patient. Avoid foot drop. I talked about that when we were in lab the other day. External rotation of the hip. We want to avoid that if they've had hip replacement. We want to do range of motion exercises. We want to do our strengthening exercises. And one of the best things that we could do is, I don't know if they have aquatherapy at any of these places, but warming up the muscles and then doing range of motion with water, especially if they have pain in the joints, it totally can help them and help, get the range of motion better for them. Now we're going to talk about the next chapter. This one is a little bit more. This is your rheumatic disorders. Oh, I wanted to mention, I think one more thing back here, that when you're in the long-term care, it's probably going to be one of your only options or your only opportunities to work with wound care and to work with your occupational therapy and physical therapy. So go with your patients and see what they're doing and have the different therapists tell you what they're doing and how they're doing it and learn some new stuff, because when you're a nurse, you're going to have your own list of responsibilities and you're not going to be able to observe what they're doing, but it'll give you a better understanding of what those different therapists do or what those different wound care nurses do, so that you know when to engage in their services and work collaboratively with them. All right, this is on patients with inflammatory rheumatic disorders. We're going to focus on rheumatoid arthritis, but mostly this is just an overview of rheumatic diseases and what problems they cause. So they mostly do manifest as rheumatoid arthritis, or RA. It's an inflammation of the joint. It breaks it down. And they have periods of remission and exacerbation. This is different from OA in that way, because OA is just, it starts slowly and advances over time, and it doesn't really go away. So the distinct characteristics are inflammation. It's an autoimmune disorder. So your body recognizes whatever is being attacked as foreign, and it's your own body tissues. And degeneration. So I will say that the joints get really deformed with rheumatoid arthritis, and it's, for whatever reason, it seems like it affects the hands the most. The hands and the fingers tend to be severely deformed. And it also has periods of remission and, well, my mother-in-law has it and she called it flares. So it'll flare up and it'll go into remission. These are the common symptoms of the diseases. I will also say that as the joints break down, when you push on those joints or feel the area, you might feel crepitus, and that is the degeneration of the bones underneath and the joints underneath. They're disintegrating. You can read this if you want. It's a little too in-depth here, but you're welcome to look it over. Here's your health history. Again, you always get a health history. When did it start? How did it start? When did you notice it? How is it affecting you today? How are they able to do their activities of daily living? Do they have a family history? When is it better? When is it worse? What have you tried before and how did it work? And who do you have available to support you, both emotionally, physically, spiritually, all those things? So I guess it's more than two, so all those things. There's your functional assessment. You can look that over. I feel like we've talked about that quite often. And diagnostic tests, that's more of a block 2 thing, I feel like. Your goals when you're treating your patients, you're going to bundle your activities. So because they're tired, you're going to give them periods of rest. You're going to teach them how to bundle their activities so that they do get rest. Work on their pain and discomfort. Teach them that as you age, if you're going to take an anti-inflammatory, you need to really reduce the usage of that. They also have other medications that they take, but really limit the use of anti-inflammatories, because they will end up impacting their kidneys over time as they age. So there's that. And there's some more interventions, different energy conserving techniques, bundling activities, activities and periods of rest. Those are important things to recognize and know for your patients that have RA. Assist their needs for PTOT, encourage independence. We're always encouraging independence for these people. Self-care, what deficits do they have? And then tailor your plan to that. Provide assistive devices. Teach them how to use them. Make sure they're using them safely. People may feel a loss of control over their lives because of the disease, so encourage their feelings and verbalization of that, and help them understand that they're going to have to come to a new normal and identify how to cope with the disease. We're going to keep an eye on them. There's a lot of different medications we can administer. Remember that your rheumatoid disorders, your RA, is a result of an autoimmune. Your body's attacking itself. So more than likely, they're going to be on biotherapies or immune modulators. Those are going to affect them in a variety of ways depending on the medication that's chosen. So they're going to have to follow up with their physician that ordered those therapies to verify that they're not damaging liver, kidneys, lymphatic, white blood cells, all these things. Whatever the medication is, and the indications will be there with the medication. If they're new with this, you're going to explain the disease, how to manage the disease, that it's going to have periods of remission and exacerbation, that how they can give themselves their medication, what they need to know, when they need to call their doctor, when they need to see their doctor, how they can manage their pain with not using anti-inflammatories all the time, but what else can they do? How do they cope with the stress of it? All of it. How do we help supplement their diet? And then here are the interventions to maintain their functional ability. So they're going to lose it over time. It'll progressively worsen. However, there are things they can do to maintain their mobility for as long as they can. Here's your list. And remember, I mentioned pool. Pools are low impact, and they allow for more of a range of motion without stressing those joints. So it's important that if they can get some aquatherapy, that they do that. And guess what? That's it for this chapter. 12 minutes, guys.